order, please. I think, Bob, you're up first.
Okay, thanks so much, and apologize for the technical difficulties. Just one request today. It's a request for authorization for the board to allow us to enter into an agreement with the Coastal Mental Health in Brunswick, Maine. We have one of our clients removed up to Maine where his parents live, but he's under an order of supervision from the family court. And we are trying to get him, we're trying to help him do his services, and he will not be able to do this service without me entering into this contract.
Any questions?
I'll move it. Morel.
Second,
Patsy.
Patsy, all in favor?
Aye.
Aye.
So carried.
That's all I had, but I'm going to stay on, Chairman, just in case there's any questions come up in the future. And again, I apologize if I held anybody up because of the technical difficulties.
No problem. Thank you, Bob. Who's up next, Kelly?
Jessica.
Jessica? Hi, Jessica.
Hey guys, how are you?
Good.
My agenda is kind of going to flow, and you have to remember that I'm working out of 2 years right now. So it's going to start with my 2020 resource allocation package approval. We received that letter on April 2nd, and I did forward it to Chairman Morel and to Chairman Lagonia. So that allowed us to go into my next topic, which is the 2020 claims. We were able to submit all of the claims for 2022 OCFS for county reimbursement now. We were able to expend the entire allocation, even though summer programs did not run. We were able to expend them through all of the agencies that we contracted with, and we were able to reallocate all of the funding from the summer recreation programs to those programs. So they were able to have a little bit more money this year to run their programs, which I think helped out a lot because a lot of them were doing virtual programs and had to purchase equipment and things like that. And so they were going to be really short on cash anyway because of COVID. So it worked out well, and we did get the entire 2020 allocation expended. So with that being said, that brings us into the program annual assessments, which OCFS has finally entered into QUIDS. I was able to get all of them released to the funded agencies last week. They are due back to me by Friday, April 30th. It's going to be a little bit of a smaller process because obviously I don't have to worry about all of the municipalities as well. But I'll get them entered into the state website electronically. They no longer want hard copies of anything. So they've mainstreamed it a little bit and made it a little easier on us, especially for some of the smaller bureaus. Applications, 2021 applications, I'm going to be getting out. I'm going to do a due date of May 28th, which is a Friday. I have reached out to the agencies that are providing year-round funding, and they will all still be applying. And like I said, we're going to do that due date on the 28th. So hopefully they can get all of them in by then. And then that's going to bring me into the summer recreation program. I've reached out to all of the municipalities so far. I've only had a handful of responses saying that they are going to run programs right now, and that is Hillsdale, New Lebanon, and Kinderhook. We have a lot of questionable ones, iffy ones that weren't sure that they could run the program within the guidelines because they're old guidelines from 2020. I sent all of the state guidelines to all of the supervisors, whether or not they're running the programs. I did send them to everyone. And Kelly, as you know, I CC'd you on all of that too. Let's see. Any of the municipalities that will not be offering a summer program will have the option to have their funding reallocated to funded agencies. Like they did last year in order to get our funding expended. We don't want to send anything back to the state at this point. So I'm going to give the option to the supervisors. Once again, whoever is not running a program, I'm going to ask that they either pick an agency that we provide funding to, or I go ahead and just reallocate however I see fit and however my board sees fit, as long as the supervisor's okay with that. I do request that they send me an email or some type of notice saying that they're not going to run their program, and that it gives us the okay to get that funding reallocated to the other agencies that will be providing the funding. So that covers us if we're ever audited and they want to know what happened to that, you know, whoever's funding went where. There's no changes in the application process. If any of you have any programs that you think you might want to run in the fall at your municipality, I know we had 3 municipalities last year that gave their funding to their local library that was running programs. So that's an option too. The only thing is that if you go to one of your chosen agencies instead of one of the funded, they have to kind of scurry around to get an application completed and submitted to me. We can't just go by your applications. They have to submit an application specific to what program they're going to use that funding for. So that's something for you all to think about too. Let's see. Okay, I had a meeting. I know there were some questions about me collaborating a little more with DSS and some other programs and agencies. I did meet with the commissioner, the deputy commissioner, and the director of services. We're going to begin working, it's that time of year anyway, we're going to begin working on the update for the 5-year child and family services plan. It goes until 2023. So this is the midway update that we're going to start working on. And we also talked about future collaborations between all of our services, because we found that a lot of the programs and agencies that I provide funding to, sometimes DSS already works with them. So we're going to see if we can maybe try to mainstream some of those services, research getting a little bit more money for them. And then we did some troubleshooting too with whether they're providing efficient services and whether the services are actually being effective, which my program annual assessments would help out with that too, because it tells the target population and how many youth they're actually serving. So I'm going to compile some of that information for the commissioner for next time we meet. We're scheduled again in May, and go over that. And then just see, you know, what we can do and see if we have any duplication of services that maybe we could mainstream too. So we're taking steps, you know, to working a little closer together. And that's all I have. If anybody has any questions, I'm here.
Any questions for Jessica? Linda?
Yeah, just curious, what are the total allocations money-wise that you're handing out?
Well, last year was 2020. Did you receive my emails that I sent?
Does it change this year? It was like 60?
We don't
70,000?
know. We haven't gotten anything yet. We won't get that until after the budget's passed. And depending on how OCFS is working during the COVID-19, like last year, we didn't get any allocations. I think it was September. So we never know until we actually receive it.
Just from experience, sometimes after the budget passes, it takes weeks for the numbers to actually come out from DOB to the county.
And then we also lobby as the Association of Youth Bureaus. We lobby for funding because they sometimes will receive add-ons after it's already passed. So we try to send letters to our, you know, the senators and assembly and, you know, for support from them for these. They're not huge add-ons, but they help. Every little bit helps.
Any other questions? Thank you, Jessica.
Thank you.
Human Services, Rob.
Human Services.
Okay. Good afternoon, everybody. Before I go into the overtime report, I just want to welcome Amber Klein to this, her first Health and Human Services meeting. I've asked her to attend in much the same way that Michael Cole had me attend, mostly for her to be an audience member and a student of the process, so that should the time come where I cannot be the primary presenter, she can fill in for me. So, you know, I just want to welcome Amber to the process. And some of you I know are familiar with her, but those that are not, I just wanted you to be aware of who she is. And her role with us, as you I'm sure all know, is the new clinic director. So welcome, Amber. Thank you for joining.
Welcome, Amber.
Thank you.
The overtime report is pretty simple, as you have it in front of you. We budgeted $12,000. So far, we've used a total of $660.54, bringing the balance to $11,339.46. The first resolution that you have in front of you is as a result of a recent resignation that I was informed of. I believe it was last week. So this person hasn't vacated their position yet, but we'd like to go ahead and proactively seek your support in filling that vacancy with a lower grade. This person was a psychiatric social worker. So as I believe all of you know, we've revamped the titles and we are seeking to backfill the vacancy with either a 17C or an 18C, whichever we're able to find through our job search. And there will be a savings to the county on this. If you scroll down, Kelly, it'll show approximately close to $13,000 savings there. 12,000. What is it? 881.
Any questions? A motion to approve?
I'll move it.
Fury, second.
I'll second. Mossman.
All in favor? Aye.
Aye.
Opposed? So carried.
Thank you. This next resolution has to do with a service agreement between our department, the Department of Human Services, Mental Health Center, and the Mental Health Association of Columbia and Greene Counties. This is something that is renewed, I believe, annually. It's just a procedural thing. So I'm asking for your support in renewing this service agreement. There have been no changes from the previous service agreement.
I'll move it, Morel.
Second.
Abdul, second.
Abdus, all in favor?
Aye.
Opposed? So carried.
And this third resolution and final resolution is, again, similar to the previous one. It's just a procedural one in that we contract with several recruiter agencies to assist us with needs around identifying prescribers, psychiatric nurse practitioners, et cetera. So we've listed out the recruiting firms that we would like to continue to collaborate with and contract with. So I ask for your support in approving this resolution.
Motion.
I'll make a motion, Patsy.
Patsy, a second.
Abdul.
Abdus, all in favor?
Aye.
Aye.
Opposed? So carried.
Thank you, everybody. I would like to address just one of the agenda items that's on the Department of Human Services agenda, which is I want to inform the Health and Human Services Home Committee of a development that occurred. It was an unexpected surprise to me in that I received a communication from Better Health Northeast New York, otherwise known as BINI. That is a performing provider system that we have belonged to, the Department of Human Services has belonged to over the past several years. This performing provider system has been helping us, along with several other providers, as far north as Albany on down to, I think, Westchester area, prepare for the transition to what's known as value-based payments. So our participation with BINI has yielded financial benefits in terms of we have provided them with data, we have tracked several metrics for them and reported back to them over the period of the past 4 or 5 years. Well, this initiative has sunsetted, it has ended. And what I was informed of is that in appreciation for our participation and based on the level of our participation and also the performance that we performed under throughout all of the different initiatives that they assigned to us, we were awarded a check which should be arriving in the next 30 days of $588,000. So I'm very pleased to report that. I've asked both Chairman Lagonia, Chairman Morel, and Controller Campanera for a meeting when they should have the time so that we can talk about how that money will be allocated. And I look forward to having that conversation. But I just want to bring this up to all of you because I think it speaks to the collaboration from all corners of our floor here at the Department of Human Services. Every member of the department pitched in various ways to, gather the data, provide it, upload it, memorialize it in the different ways that we created to track it. These are not things that we had previously built. So we had to build them. We had to then track it. We then had to, crunch the numbers, so to speak, and then also upload it to Better Health Northeast New York and respond to the more elaborate requests that they had based on the initial data that came in. So it was an evolution. It was a process over many, many years. So I'm just extremely grateful for their financial thank you is what I'll call it. And I think it's going to go a long way, whether it goes towards us putting it towards some sort of programming that we discuss or towards our deficit, which, as everybody knows, is quite significant. So I look forward to that conversation. I just wanted to let everybody know about that. And I'll be happy to answer questions about that if there are any.
Hey, Chairman Lagonia and Dan, can we meet maybe on Thursday?
Yeah, that would be great, Chairman. Sure, because I am going to be away from the office next week, except for the Community Services Board meeting. So I know there's a lot of urgent matters kind of flying around. I just wanted to let everybody know that I will be unavailable next week. But if you need to reach someone at the department, please feel free to call upon Amber, and she'll do her best to
That'll work.
respond to any questions.
Did you say that works?
Yeah.
Rob?
I think so, yeah.
All right, I'll have Kelly set something up.
Great, Matt. Thank you.
Okay, thank
And
you.
then just one final thing, I'd like to make everybody aware of a very recent development, which came to my attention just this morning. Otherwise, I would have, brought it to the budget work group ahead of time and done a resolution. But I was informed this morning that one of our clinical supervisors will be resigning. Her last day in the office is expected to be May 18th. So I may be coming to with an emergency fill at some point in the very near future. I just wanted to give a heads up about that. As you know, we're actively trying to backfill for several positions. So we're going to be talking, Amber and I are going to be talking about how we're going to strategize this with an internal candidate as a promotion. There is no list. So I'd definitely like to opt for the internal candidate option as opposed to identifying somebody from the outside. I think it's always better when we can promote from inside, and that's going to be my aim at this point. So I just want to make you all aware of that. And that's all I have.
Thank you, Dan. Any questions for Dan? Great. Thank you, Dan.
Okay, much appreciated. Have a good evening, everybody. Bye-bye.
Thanks, Dan. I'll call you this week.
Okay, thank you. Bye-bye.
Public Health, Mr. Mab?
Yes, indeed. So the first resolution, are you pulling them up, Kelly?
Yep.
Okay. Okay, so we have smart health claims for billing. One of the things that we don't have here, and it really hurt us bad with this pandemic, is electronic patient records. We never thought that there was a reason to get it because it costs money to get electronic patient records. We knew what the pluses were, which is ease of putting data into systems like NISIS, but we kind of held off on doing that. We got Smart Health Claims to help us with our billing, but it has no integration whatsoever with any part of the state. It is not an electronic patient record. We went looking for a system that we could develop electronic patient records that helps in a ton when it comes to putting data in for billing and also into NISIS for the information on the patients. We found MedDent, which is going to cost us about $250 more a month, $3,000 a year than Smart Health Claims, but it is an electronic patient record. which means that everything gets migrated over to NICES automatically. There's a lot of work that goes into doing that by hand, and I'm part of our immunization clerk. It also will help with billing, coding when we do our billing for immunizations and whatever. And that's going to cut down on time for our bookkeeping staff. And you know, as important is it would have helped a lot as we've moved through with all of these vaccines. But you know, as you know, there's going to be boosters necessary out there. I don't know how you booster the whole population without involving local health departments. I don't think you can send it through doctors' offices. So we're going to be doing that. And then, you know, future flu clinics that we do, it'll be a breeze doing the clinics. So we're looking for approval to adopt the Medit system rather than and abandon smart health claims.
Motion,
I'll make it Bury.
second,
A second, Mussman.
all in favor?
Aye.
Opposed? So carried.
Thank you. That's really huge when it comes to the workload down here. So back, you know, in the other pandemic that never happened, Ebola, we were required by the state to contract out with an environmental group, environmental company that can come in and clean up if we had somebody who was in an apartment and had Ebola. We contracted with Miller Environmental Group, and this is really just a renewal on that contract at this point. We do have to, you know, as you may know, Ebola has sprung up again, and we have been told we have to maintain the contract. So this is just a renewal on that.
I'll move it. That's-
Abdus, all in favor? Aye.
Aye.
Opposed? So carried.
So Stericycle is the company that handles the sharps for our department. We also take sharps from mental health and send them off on a quarterly basis. Needless to say, we're going through a lot more sharps now that we are doing pods and whatever. And so this is a modification of the contract for a year or two, you know, increased to a monthly charge, picking up on a monthly basis, so we can get rid of the sharps that we're doing at the pods.
I'll move.
Morel, second.
Second.
Second, Abdus, all in favor?
Aye.
So carried.
Those are my resolutions. My report is, my monthly report is here. If there's any questions you might have on the monthly report, or certainly on our COVID activity, if you will. We did have, as of this morning, we had our first positive animal of the rabies season. It was a feral cat that unfortunately was being handled over the course of 4 or 5 days by a local veterinary group. And there was at least 3 staff that were handling it. They have pre-exposure treatment, but once you have an exposure, you have to get post-exposure treatment. So they're going through the shots at this point, but the season started. You know, it's just one more thing to think about.
Jack, I just want to thank you and your department and all the volunteers you were able to muster up for doing all these clinics and all the extra stuff that you've been doing in this really hard time. Very, very good, very professional. Thank you.
Yeah, you're welcome. Thank you for attending our clinic. We are as of yesterday, we are closing that chapter, if you will, to some degree, and starting a new chapter. We last Thursday and Friday we had 220 shots to give out, and we only gave out 105 on Thursday and 121 on Friday. So we have Moderna left. We have reached a point. I say we collectively, the state, other LHDs in the community. The vaccine supply is now larger than the demand. And so we realized that those days of doing 500 or 600 people at the college are probably over, other than our second doses, which we have a 600 shot pod coming up on Thursday, but for second doses, we are going to start hitting the road. We're going to be doing some pods at various locations in the county. We're doing a Hudson pod this weekend. And we're talking about Chatham Fairgrounds. We have MOU we signed today for that building. We contacted Taconic Farms and Flanders, Krellin, and at least one other, Novapac, which is now something else. I'm not sure what it is. They're interested in us doing on-site pods for them. And this is going to be our new life. We're going to be doing a lot of smaller pods in around some of the towns. Have people that we have talked to the New Lebanon supervisor who says New Lebanon's pretty far out from Hudson, so we'll probably end up doing a small pod up there. We are also trying to get Pfizer to do school-age children. Last week, Tuesday, Wednesday, all the schools sent out letters to parents indicating that we would be doing pods right at the school. And I'm a little disappointed with so far. I heard from Germantown. So far, they've only got 8 people who want it. Ichabod Crane told me this afternoon, that they had 14 so far coming back. I think there's going to be a lot of vaccine hesitancy out there. Part of the reason why we've seen the interest drop off is the younger people are now eligible, the 18 to 30-year-olds. They're not coming out. They're not interested in the shot. So we're going to start, see Kevin down there in the corner. We're going to talk to him. He's just opening up some of his senior sites. We can do a pod there. We can come out and vaccinate folks who are attending that, or also who want to come in to get a vaccine. So those are all the kind of thoughts that we have in terms of what we're going to be doing.
Let me know if you need any help here in Germantown, okay, Jack?
Yeah, will. Absolutely.
Mr. Morrell?
Yeah, Jack, I contacted Sam Parker again after our call today, and he's still working on the Pfizer for us, so it's not a dead issue yet.
Well, I think if he can work the angle, and if you want to recontact him, Mary Fran from Rensselaer County she put in for a full tray, 1170 doses, and which we would go in with her. And if he wants to work that angle, she put it in for next week. If he could just support that, that would be fine. That would be fine with us.
All right.
Any other questions? Thank you, Jack, as always.
Okay.
You've got OFA, Rob.
Good afternoon, folks. How are we doing?
Good. How are you?
Before we get to I had 2 resolutions. Before we get to them, as Jack had alluded, we are planning on reopening some of our senior centers late next month, particularly Livingston and Hudson. Like I said, I'm going to be working with the supervisor from Livingston, and I'll have contact with what's her name, Robin. I can't forget her. Robin Waters. I'll be contacting her. She's the Hudson senior advisor, and I'll be contacting her too about the specifics. But our contracts are all in place, and we're ready to go. Some of these folks are really itching to get back. We've got special guidelines and protocols in place. We've also reached out to Town of Copake, and we're working with the supervisor there, and it looks like we might be on board to open there sometime in early June. Okay, if everything works out okay. So we're kind of excited about that, getting things back to somewhat a little bit of a normal. So, but okay, getting to my resolutions. Let's see, what's the first one we have up there? It's a financial resolution to accept a grant in the amount of $31,893 from the New York State Office for the Aging. I guess they must have got some extra funding from the feds regarding COVID-19 related monies, and they're passing it on to the counties. And we just wanted to amend our budget to show that we have that extra amount, and we'll obviously spend it, on our seniors. So,
Motion to approve.
Patsy.
I'll do second.
All in favor?
Aye.
Aye. Opposed? So carried.
Okay, thank you. And my second resolution is to seek permission to fill the position of a site manager position. We have had this was vacated back in December due to a retirement. And since our sites were actually, were temporarily closed down, we didn't see any reason to quickly fill it. So, but now that our sites are going to be reopening, like I said, we figured this was the time to make this presentation. It pays $17,000. It's a 4-hour-a-day position. And like I said, it replaces Supervisor Eldridge. It replaces the site manager that worked in Greenport. Like I said, we don't have a hurry to really fill the position, but we just wanted to get permission to do so. Like I said, because all of our sites aren't going to be open immediately. So, but we just kind of wanted to have this ready to go if and when, we do need the position.
Motion?
I'll make it, Bury.
Second? Kathy? All in favor?
Aye.
Opposed? So carried.
That's all. Other than this presentation, that I can't believe it, Kelly. It's actually 4:30. It was perfect timing. You must be a pro at this.
I'm getting there. I'm getting there.
I guess you are. Wow. Anyway, I've asked. We've been approached along with the State Office for the Aging. We were contacted by a group known as Everhome Columbia Incorporated. It's a nonprofit agency, and their wish is to conduct a pilot program here in Columbia County to allow our elderly population to safely and comfortably age within their own home. It's kind of a unique concept that they're proposing. And like I said, I don't know if it's been proposed for Columbia County. I see Lou Piro on. Lou Piro's a Hudson native. Hello, how you doing, Lou? And he's involved with this company, and they would like and I'm sure we're going to be hearing about this down the line. That's why I thought it might be a good idea to have them make a brief presentation so that if and when people start hearing about this, they can kind of know what we're talking about. So, Lou, as long as if you're ready to take over, you got the floor, I guess.
We are, and we have a PowerPoint. I'm hoping we can get up so that we can share that with everyone.
So whoever is going to present it, just hit the present now button on the lower right-hand corner. Be sure the file is open somewhere on your computer before you do that.
Cameron, do you have the deck open?
I'm getting it right now.
And then you're going to select a window once you click on the present now. And you should be able to select your file.
While she's doing that, I can give a little background. I know most of the people, I think, on the call here. Certainly, I've known Matt for pretty much all my life, and some of the others as well. What we're trying to accomplish in Columbia County, we hope, is something that can then be shared across New York State and, in fact, across the country. And if you are following what's going on in the Biden proposal for infrastructure reform, part of his infrastructure, which is not infrastructure, is $400 billion for home care services under the Medicaid program. And what he is seeing is what we are all feeling. And I'm an attorney, I practice elder law, and my clients are struggling tremendously trying to find home health aides, coordinate care at home, and have a solution that is in fact affordable for them. So Cameron, we can go to the first slide. That one. So we're going to talk the second slide, I guess.
I've got it. Mm-hmm.
So that's our agenda, brief agenda for 15 minutes. We're going to present the highlights for you. So we've been working on this now for a couple of years, and we started meeting with people from the hospital, Dr. Pope and others at Columbia Memorial, and we were working our way through this process. And I happened to be sitting, I won't tell you where, but next to Rick Cummings, somewhere where we were both having a conversation over a pint. And I said, we're proposing this for Columbia County. And he said, well, I'm on the board of the Home for the Aged, and we're looking for ways to help Columbia County and to build out services for aging residents. And so we looked at it together and said, well, this might be a way that we could take what you're looking to do and combine it with our program. We then had the good fortune of having Greg Olson as the director of the State Office for Aging and Kevin be participants, and we've been talking through how this may work. So we're going to walk you through what the pilot is. And in fact, next Wednesday, we make our final pitch to the HFA, the Home for the Aged. And our pitch is to take the Home for the Aged, which, if you know them, they ran a facility, they ran assisted living in the city of Hudson for Columbia County residents. And that's their mission, to take care of aging residents of Columbia County. But they're not in the facility business anymore. So they have funds that they're looking to find meaningful ways to help people who are aging in Columbia County. And today, a lot of it due to the pandemic, but even more so before that, people want to age at home and be able to bring services in. That's why the Biden administration is looking at funding that. That's why the state is looking at ways to improve the quality and quantity of care in the home. So our presentation is going to talk about the hands-on care, but how that can be augmented and supplemented using state-of-the-art technology. And we'll walk you through how that works. And Cameron, if we can go to the next slide.
Oh,
So,
sorry. Went ahead of myself. Hold on, Lou.
okay,
Sorry about that.
there we go. So the proposal is to create a consumer-driven care coordination model and to take all of the services that are available today. And we're working with the County Office for Aging. We're also working in conjunction with the Healthcare Consortium and the EMS services. We've been in conversations with PJ Keeler, the hospital, and how we can bring a home care program together that integrates all of the available services, makes them available, and makes them affordable to people in their own homes. So next slide. We created this not-for-profit Everhome Columbia Inc. And we're working hopefully with HFA to create virtual homes for the aged in Columbia County. And I'm going to turn it over now to Nora Barato, who is our Director of Client Services for Everhome Care. Nora?
Hi, everybody. It's nice to have the opportunity to talk about this. Our pilot timeline is a 24-month duration, and the first 6-month development would be the VivaLinks application development. And also in that time frame, phase 1 would be a staggered rollout. What I mean by that is we would identify the client population in collaboration with NYSOFA and Office for the Aging, and work with Columbia physician practices in identifying clients who really are, they would benefit from the use of wearable technology. And in addition to home care that they have, many people don't have home care because they can't get aids. So we're about identifying those people that we really think would benefit. And there are a lot. Phase 2 would be the pilot kickoff.
We're still on the same slide.
Okay, the pilot kickoff, and that would be, we would market the pilot and the technology so that everybody has a clear understanding, because we really need to work in collaboration with the agencies that are existing. We're not meant to come in and take over, but supplement, because the aging needs, as you all know, it's all hands on deck to help meet those needs because they're very comprehensive. Phase 3 is the go live and ongoing enrollment. Now the dates we have, July 2021, those will vary according to when we get funding in that. And then we would have the pilot rollout and realignment of roles and responsibilities, and bi-weekly stakeholder meetings and ongoing education and marketing to the business and community agencies. Next slide.
If I could, Nora's background, she ran the the case management, care management component at St. Peter's Hospital. She's worked in healthcare for going on 30 years and was the head of discharge planning. So she understands what happens when people move through the healthcare system to go through hospitalizations, rehabilitations, and then back home. What the goal is, and Alan Evans, our VP of technology, is going to explain how. Our goal is to use technology to predict events and to help people before they need that EMS hospitalization, and to keep them in the home using a series of different interventions, including something that the pandemic has given us in great quantity now, which is telemedicine. So the vision, Nora, the triple aim is the goal.
Right. We want to improve access to care and reduce readmissions and unnecessary emergency department visits. What I've seen over and over again in my 30-year career is that, people get anxious, and during that time, they're instructed, oh, go to the ER, go to the emergency room. There's a lot of technology you can put in place, such as wearable devices and that can help us identify problems early on before they even get to that crisis point. So that's what we really are looking at. Other technology, fall detection. Those are things that we could put in the home that are not, over invading people's privacy, but that can alert us to potential issues ahead of time. We also want to look at improving service delivery through the development of a cross-continuum team. Nobody, as I mentioned before, because of the multiple problems and barrier access issues, nobody can meet the comprehensive needs of the older adult without a team approach. So that's what we strive to work with, developing that team. And improve communication across the disciplinary team. I don't have to tell anybody the cutoff between the health system and the community. And we really want to work side by side with the physicians and be that link. And it does work. I've done it in my previous 30 years, and it really does help when the doctor and the community agencies are in collaboration and know what's going on. Next slide. So our pilot structure, we want to have look at being in 400 homes. The breakdown would be 200 clients through the Office of Aging, which is supported by NYSOFA and Homes for Aging and Columbia County Office for Aging. We were looking at having around 150 clients that it would be privately paying, and 50 Medicaid long-term care program members that would be subsidized by Medicaid and the Homes for the Aged. Our program duration would be 24 months, and as I mentioned, it would be a staggered rollout. And we would have ongoing support and maintenance, and Everhome Columbia Inc. would operate in collaboration with Homes for the Aging, and we would have a Home for the Aging board, one member on the board, and then we would have a 10-member advisory board. Next slide.
One of the, and Nora, just going to speed it up a little bit, but one of the things that we're looking at right now, many of the services that are available to individuals are siloed. If you go through the Medicaid door, you get Medicaid services. If you go through the Office of Aging door, you get Office of Aging services. And if you're private pay, you're out there trying to find services on your own. What we're looking to create is a system that can accommodate all people of all means. So people that don't have the ability to private pay, that are relying on Medicaid, we believe can be funded through this type of a home care service. People with Office of Aging have some resources, but not enough to fully private pay. So they would be subsidized. And then those people that can afford it would be paying. But we're going to take the services and put them across, as Nora said, the continuum of care, so that they would apply to everyone, regardless of the payment source. And you all know the population of Columbia County better than we do. So I don't think we need to spend a lot of time here, but it's an aging population where people want to have the ability to age in their own homes. And that's the same all over the state and in fact, all over the country. So Nora, just briefly on the next slide, how we get through this and how we start enrolling people.
Well, again, as I mentioned, we want to identify potential clients, and how we do that is through collaboration with Office for Aging and the medical folks at Columbia Memorial. We need to also get the client's consent. We can't do anything without that individual being informed about what the potential pilot is and do they want to be involved in that. If we get their consent, then we would share data. People don't want to be assessed and reassessed. So I'm very mindful of that we share as much information as the client wants, so that we're not rehashing and redoing everybody's assessment. We'll do the preliminary intake with that client and or family or caregiver, and also look at what services they currently have in place so that we are not duplicating any efforts and we're collaborating with those providers that are already in place. What type of care is needed and how is it going to be paid for? And then once we get through all those questions, then we would go ahead and schedule that meeting to conduct the assessment.
And that's an in-home assessment.
Right.
And I'd like to now introduce Alan Evans. And Alan is our Vice President of Technology. So the tool that Alan is developing is an app that is going to take different technologies. There are right now 6 in our bundle that he'll tell you do a number of different things, all different things for people in their own homes. And we're going to aggregate those apps into a single, very friendly user interface that will allow us to bring these people in, allow their families to help and be in the loop and help manage the care along with a care coordinator, and then have that data be available to the Office for Aging, the Department of Health, the physician, the hospital. The appropriate data points would be fed through this system. And Alan, take it.
All right, thank you, Lou, and thank you, Nora. So really just picking up where Nora left off. So once the assessment is complete, the care plan is then created by what we call the Life Care Coordinator, or the LCC. So nearly all activities moving forward are driven by this care plan. So as you can see here, we talked about 6 different technology partners, but we're going to focus right now on these 3, which is eCaring, Alarm.com, and UCM. So if we go to the next slide, we can see what the process is with the VivaLinks application, where the care plan informs the roles and permissions, basically defining what each user can see and what each user can do. The care plan also drives the setup and the configuration of the VivaLinks integration partners. Again, that's eCaring, Alarm.com, and Universal Concierge Medicine, or UCM. And all our program participants, as Lou just described, will have access to this program as the participants. They'll get the information based on the outcomes of the pilot. And moving forward, all the participants will always have access to this data as it's generated through this whole process. So if we go to the next slide, we see the workflow and onboarding process for eCaring. Now, eCaring is the electronic health record technology. eCaring customer health information and data is updated regularly by the primary caregiver. This customer data is continuously pushed to the cloud, where it becomes available to all customer care coordination software systems that have been integrated with the VivaLinks platform. The next slide is where we focus on Alarm.com. Alarm.com is the hardware, sensors, and monitoring systems platform. The care plan determines which of the Alarm.com features are activated. This can be bed and chair sensors, two-way communications, video, security, and more. All monitoring data and activity tracking is sent to the cloud and made available to the other systems that are integrated with the VivaLinks application. Constant monitoring allows for continuous learning and pattern recognition. It understands and learns about the normal patterns of the person being cared for. Eventually, through this advanced intelligence and machine learning, the system becomes proactive and will potentially alert caregivers before there is a critical issue or emergency situation.
And Alan, I'm going to jump in here because I happen to have an aunt who lives in Hudson who's going to be 99 in August. She lives alone in her own home and she didn't have any kids. So she has a bunch of nieces and nephews, and she was suffering from falling and having a few issues at home. So we used our other care manager, Susan Vale, who was part of the Everhome care team, who went down, met with her in her home, did the assessment, recommended the implementation of alarm.com technology. It met with resistance, and you'll see there's another Piro on the screen. Mary Ellen is our RN who's going to be working with us as an RN coordinator as part of the pilot. But we are all now using alarm.com for our aunt, and we are tracking her movements, tracking that her safety, her ability to stay in her own home with minimal care. And at 99, that's kind of a miracle. So it works. And we met with resistance from my cousins who said, what? You're going to do what? Once they got it on their phone, once they used the app, and once they saw how easy it was to manage the care, it became a no-brainer. Now it's all ingrained in us, and we communicate and we use the technology as families will. So we think we're maybe 2 years ahead of the curve, and all this funding is going to be coming down the pipeline later. But we have an opportunity to put Columbia County out in front of that curve and create this system for county residents right now. Alan?
Thank you, Lou. That was great coverage there in terms of real life experience with how this is going to work. And so in case of emergency, Universal Concierge Medicine, or UCM, comes into play. UCM is our telemedicine and triage system. It's used by the emergency doctor that gets activated through the system, with the extraordinary benefit of visibility across all customer data. Remember, all that data is continuously pushed to the cloud. They're then able to address and resolve the situation when there's an emergency, resulting in one of three primary outcomes. It's an ongoing chronic issue that requires remote consultation or prescription. And that's the end of it. Or a true emergency that requires immediate life-saving intervention, at which point they would call 911 and arrange for emergency transport. Or simply there's additional follow-up care or referral that's needed at that point.
And I'd like to introduce next our Chief Strategy Officer, Camerine Robinson. And Camerine's going to walk us through some of the strategic alliances that we've been able to develop.
You're muted, Camerine.
You have to unmute.
I get muted. Can you
There
hear
you
me?
are.
Okay. I believe Kelly muted me a few times because of background noise.
Yeah, there is. Sorry.
Thank you. No worries. It's okay. Let me just bring the slide up so I can I'm navigating the slide, moving around slides also, so bear with me. All right. So in addition to outside of having our vendor partnered, it is critical to have the right strategic partner involved in the pilot program to ensure success measures are made to attain the triple aim goal for the pilot participant. With that said, through our strategic partnership with the New York State Office for the Aged, the Viva Links app will help drive the NYSOFA advocacy role to improve the lives of New York State elderly population. And by doing so, will impact the population health. It also, everywhere you go nowadays, you hear about the social determinant of health. It's a big movement. The whole point of the social determinant of health is to make sure that the elderly population can remain at home and have the community care that they need to age in place. It also will help with disease prevention to improve the healthcare outcome. The relationship between the NYSOFA staff and the Everhome Licensed Care Coordinator, I know Nora touched base on this a little bit. We'll work together to collaboratively identify Columbia County candidates who will benefit the most from the assessment, the intervention, and the appropriate provision of technology-driven solution. Our partnership with NYSOFA will utilize human resource appropriately and effectively. And by doing so, creating visibility and access to resources, not just on a state level, but on a national level, to ensure that the consumers receive the triple aim, which is the better care experience, the better health outcome, lower healthcare costs. It requires a very streamlined approach to work and an identification process to help the consumer, to help fill the consumer needs that will lead to a sound, not just solution, but outcome. A lot of our strategic partner outside of the New York State Office for the Aging is the County Office of the Aging, Kevin's team, and also the Healthcare Consortium. Each role for the Healthcare Consortium is to help to facilitate connection to local providers within the area to really bridge the partnership and help the pilot roll out more effectively.
I don't know if you all know, I know Kevin is intimately familiar with the work of the consortium. Claire Pardee is the head of the consortium, and we had a meeting with her. She's going to help us present next Wednesday to the Home for the Aged. But the consortium is the provider for the State Office for Aging's New York Connects line. And New York Connects is supposed to be an answer, a solution set for people who call, who have aging parents who are looking to integrate and get services in their homes. But as Claire said, we can give them information, we can give them referrals, but we don't have the facility to solve the problem. What this Everhome pilot is going to show is that there are solutions, there is care management, there are technologies that can link that caregiver child, whether they're calling from California, Hong Kong, or the next town over. This can link the whole family as caregivers and allow them to participate in and have some control over how that care is being provided to make sure that it's quality assured.
And, Lou, just to add to that, it's not just, it's an all hands deck approach to make sure that this pilot is successful. It would require also working with Home Care Association of New York, which includes home care agencies throughout New York State's, healthcare providers such as the local hospital, Columbia Memorial Hospital, the Columbia Memorial Physician Practices, and the Columbia County EMS Services. And I can tell you, I've been in the industry for over 25 years, working with a lot of the stakeholders, such as the health plans. And I can tell you, I've been in this business for a while, working with the Medicare and the Medicaid population, specifically with the elderly population. And I can tell you that this product and service model that Everhome is rolling out, it's needed. I don't think I've ever met a senior that says, oh, I want to be.
I think we're losing Cameron.
Can you hear me?
Got your back.
You can hear me now? Okay.
Yes.
And then in addition to that, some of the stakeholders that we were talking about was the managed long-term care plans, such as visiting nurses, Fidelis Care, and Aishansha. These organizations are all the stakeholders. It's important that we work together to roll this product out, and it's an ongoing process to do so that people can age in place in their home. Next slide. So the big elephant in the room, right, is the COVID pandemic, the current market dynamic. Prior to COVID, there was this big shift to where people wanted to stay in their home. But with the COVID, it shows basically that the pandemic's reshaping the way America cares for their elderly. Before, it was just a subject matter expert that saw the need for it. With everything that went on with the deaths in the nursing home, it kind of shed a light. It sure shed a light on the importance of keeping seniors in their home. The big insurers, the healthcare companies, and some hospital system right now are betting the new pattern of referrals and care established amid the crisis will remain in place for a very long time to come. This is a very dynamic piece here.
You can skip this one. We can go to the next one, but that
will be you then. Do you want to do?
Yeah.
Okay.
And it isn't just the baby boomers. They're the ones coming through now, the front edge in their early 70s, but 10,000 a day are retiring and going on the Medicare program. Behind us, you look at the Gen Xers, that's another 66 million people who will be the caregivers for the baby boomers as they age. They are all technologically savvy. Adoption has been the problem with technology, but I can tell you from my experience that my aunt doesn't touch any technology in her home, and none of these programs require that the senior be hands-on with any of the technology. Next slide, Cameron. So the impact on caregivers, and I was and am a caregiver. I was a caregiver for my mom. That's how this whole thing got started. She lived in Hudson, developed Alzheimer's, and our journey caregiving for her is what led me to the conclusion that there needs to be a better way to do this. But the caregiver burdens, the amount of time, the amount of money, the amount of energy and emotional capital that caregivers spend taking care of aging parents and loved ones is growing by the day because the healthcare system can't provide them with solutions. And so there is a lot of study in this area, employees losing time at work, relationships being put under stress. The caregiver burden is enormous. And with this tool, the VivaLinks tool, next slide, is something that can put in place the technology. Next slide, Cameron. There we go. So VivaLinks is the tech piece of this, and that's the app and all the various tech partners. We have vetted them. We have support from all of our technology partners, and it's a market that's growing. It's going to be growing across the state, the country, and the world as our population ages. We think it has to be married to active care management. So we have professionals under Nora's direction that are professional care managers who oversee the care, educate the family, educate the caregivers, and link them with the best-in-class providers in their community. So next slide. This is our team. And Mary Ellen is, again, our RN, who has been added to the team for the pilot. But you've met all of us, I think, except our CFO, Bob Yingling. Next slide. We also have a very deep bench and a board of directors, all of whom are professionals across the country in this area. And so they guide us and help us to identify opportunities and to present those solutions. And with that, we'll open it up for questions.
Mr. Pirro, I have a couple of questions. Firstly, thank you for presenting. You said that this is a non-for-profit. So please explain to me how the financing and the funding gets to Everhome. And obviously, you're all not working for free. So how is that all happening?
Correct. There would be a contract between the not-for-profit and the company and the technology for the pilot, and we have that in the pilot detail. So we have a pilot summary that outlines how that would work. It's a good question. But again, we're putting together an advisory board to manage this, a 10-member advisory board. And that's something that some of you may be asked to be on. And we have a number of people, stakeholders in the county and from the state, that will be shepherding this process through the not-for-profit.
Okay, thank you.
Patsy Leader has her hand up. Supervisor
Pat.
Leader.
Should I sign up now? I know Kathy Eldridge and a couple other supervisors already signed me up. But just real quick, do you have enough staffing to go into the homes for this? Because, for instance, the Eddie nurses I've been having, we're having people, they have a hard time getting staff and so forth. And are they RNs or LPNs or people that go into the home? There's a lot of people that don't have any family also. And my other question would be, do you actually plug into the people's estate that they have for payment, because like a nursing home does, or any of that, besides their healthcare information, besides their insurance? Do you actually put like a lien on anything they own, or stuff like that? So that's my two questions.
So the two questions are good ones. And that's why I've asked Al Cardillo, who's the CEO of the Home Care Association of New York. The VNAs and the VNSs and all the home care agencies are members of his, and he represents them. The shortage is acute. It's very acute in Columbia County. We work with a number of families there. So agencies can't staff all the cases. We are not a staffing agency. So what a care coordinator does is calls all of the agencies in the county and sees if they have available staff. If they don't, They then work with the family to try to find other available caregivers. And in New York State, the Medicaid program will allow you to hire family members or neighbors or church members to provide care, and they can actually be paid caregivers under New York State Medicaid. The acute shortage of caregivers is why this program exists, because if we had an abundance of caregivers, we wouldn't need the technology as much. So we are not going to be staffing cases, but we will be helping families find every available resource and putting those caregivers in place and giving the family a way to manage the care. And the technology that Alan was describing, the e-caring technology, the caregiver gets a tablet, the software is programmed by the care coordinator, and the caregiver in the home, each caregiver who comes through uses that tablet. It's very simple to do, and they track all of the care that they're providing in the home, which then creates that electronic medical record. So we are not caregivers, so we're not going to be hiring anyone. We're care coordinators to help them find the care that they need and try to find solutions, which is what our care coordinators do now. Did I miss a piece of the question? I know there are two parts. Okay.
Ron Capanera's got his hand up.
Yeah, Lou, hi. Ron Capanera, County Controller. I'm personally going through this right now with my mother-in-law, 88, dementia and so forth. There's a lot of caregivers out there right now that are for-profit, right at home, for example, Visiting Nursing Association, so forth, the Yeti. Are they going to come under your umbrella, or are they separate, or are you going to be in competition with them?
No, we are not in competition with any providers. We are coordinators. So we're going to help the family identify the available care. The family, the consumer, makes the ultimate choice. What we're trying to do is empower the family to make the right choice and then to help them monitor and manage the care that's being provided.
So you're going to be in contact with all these other caregivers out there.
We already are.
Choice.
Yeah. And Nora can speak to that a little more because she's on the phone with these groups on a daily basis, helping to find the right care for people. Nora?
Sorry, I was on mute. We really develop collaborative relationships and really know and identify needs and work with other providers so that we can try and meet the needs. It's very tough, I think sometimes, and challenging depending upon where, people live in that. But I can say very honestly that we really work very hard with the families to explore different options that are, suitable to them. Sometimes, as Lou said, it's not just putting an aid there, but looking at like different alternatives, like an adult day program or a combination of different services. So it really is individualized according to what the needs are in the family and what they can do and support.
And it doesn't come down to an individual payment source for each family member?
Mm-hmm.
Whether, if they're not on Medicaid, I'm certainly that Medicare won't cover a lot of these sources right now. All
You're right.
I know that. And then it really comes down to private pay. A lot of private insurance companies like Empire, Blue Cross, so forth, they won't cover these home care services either. So it really comes down to self-pay for a lot of individuals, if I'm correct on that.
Yeah.
Yeah.
But we do think that as time goes on, the Medicare Advantage plans will be looking to pick up digital services in the home. There's already a movement toward that. None of them pay for it yet, but companies like CDPHP are very innovative and creative, and they do pay for telemedicine now. So the telemedicine component of what we do is part of most health plans today, and we just got to get them to take the next step to invest in the digital technology. I can tell you that the whole bundle, all of the technology that we have, all 6 programs, and in the pilot, we're only talking about 3, along with the care coordinator who is going to help supervise that is $300 a month. The cost of home health care, if you're paying for 24/7 care, can be $400 to $500 a day. So it allows people like my aunt to be at home much more independently without the necessity of having that staffing as rigorous as it might otherwise have to be, supplementing the hands-on care with the ability to monitor, track, and intervene if things do go wrong.
That's cheaper than nursing home.
Yeah, and I just want to add to that, Lou. Ronald asked the question about the health plan, whether they're going to pay or not. There's a big movement by the Center for Medicare and Medicaid Services and for the local Department of Health, the Department of Health, to really keep people in their home, to make sure that they meet what is called VBP, value-based payment, to make sure that all the health plans reach what is called the triple aim. And again, the triple aim is for the patients to have better care experience, to have better health outcome, to lower healthcare costs, and to really keep them outside of the hospitals. So why this program is going to make a big impact in the industry, one of our key stakeholders is not just the Office of the Aging. It's going to be working with the Medicare Advantage programs, the Department of Health, because everyone is looking at way to drive down costs. What this technology does, you heard about the social determinant of health, right? This is all about community, seeing what happens inside of the individual's home in their community, because what they found is that what brings people to the hospital is sometimes what happens, ailments, that chronic conditions that occur within their home that forces them into the hospital. So you'll find that more and more health plans where they weren't paying before, they're going to pay into a technology to participate with a technology like this, because it helps drives down their costs, which will in turn release their what is called value-based payment from the state and the federal government to keep their plan afloat. And I don't know if you want to add to that, Lou, but it's a big initiative. It's not just coming from the health plan. It's actually coming down from Center for Medicare and Medicaid Services to really change the dynamic because of the baby boomers, what we're faced with. And if you look at the generational slide that we showed you, the baby boomers is just a tip of the iceberg. This issue is not going to go away. You're going to see it again with the Gen X and with the millennial that is to come.
So this is one of the reasons that the current infrastructure bill has $400 billion in it to build out these types of technologies and services for home care. There's another component to this, which is adjusting the wage scale, because the reason that home health agencies can't find people is because an aide makes about $12 an hour doing a very, very difficult job where they could go across the street and work at McDonald's for $15 an hour. So recruiting and finding people to be caregivers is very difficult. And the people that do it for a living are doing it for a very mission-driven purpose, because this isn't financially lucrative for the actual caregiver. So hopefully that gets adjusted. But in the meantime, there have to be other modalities of care and the coordination of care with all of these islands of excellence. There are great providers out there, but they're all working in silos. This technology and the app brings all of those silos together. The Office of Aging has a whole host of different services that they provide to people, but they're very different than what Medicaid provides to people, and they're very different what other people are buying on their own out in the marketplace. This pulls all of that into the caregiver's control. And again, it's empowering the caregiver, the care manager, the family member to be able to manage all of this.
PJ has a question.
TJ, go ahead.
Yeah, just a comment. Lou, you and I have spoken a couple times. I think this is a very exciting program that you're working with. For those of us that work in the field, obviously community paramedicine is on the brink, especially in Columbia County and some other parts of the state. It's been kicked off for the vaccination that we're doing now. But the other exciting part was I was glad to see that you hooked up with UCM as your telehealth partner. We're one of the vendors that we are seriously looking at in Columbia County to incorporate into our 911 center as well. And I think that's a very good choice. I briefly saw some of the algorithms that you had there, and from an EMS standpoint, some of those may need to be tweaked a little bit. But I think you're heading in the right direction.
Thank you, PJ. We actually got those from UCM. That's their model.
Yeah.
But we have to get, as you know, both sides or all sides kind of communicating, and there is very little communication among the different levels of care. We're also hopeful. We've been talking to Keith Algazine, who is the CEO of United Concierge Medicine. We think that there are reimbursements now coming into the system for telehealth that could be shared with the EMS services.
And that's what we're looking at, yes.
They can actually be hands-on providers in home.
Correct.
Under the direction of an emergency room physician, which will give them a little added revenue as well.
Right. And that's the direction we're headed.
Kathy, you have a question?
I do. For somebody that might not understand, and I do understand what a chronic health condition is, can it be explained how this would prevent someone from going into the hospital? How they would be monitored at home with a chronic health condition?
Mm-hmm. Nora?
That would prevent this.
So very honestly, I have a client that what we have prevented, she's late Alzheimer's, and she has drops in her blood pressure. And what we've set up is with the physician is she has private duty home care, and we use a tablet to monitor her plan of care. And the home health aides are instructed that if they take her blood pressure and it's below a certain point, they're to hold her medicine. She started to have these changes where she just kind of will go unresponsive. And what we've done now is we have identified the problem. We have provided the physician with her blood pressure so he can guide us over the phone, because there's really nothing that can be done, to change that. She's at the end stage of her disease process. So sending her out back and forth to the ER, that has happened twice, but we stop that because, they don't do anything. They go and say it's orthostatic changes in her blood pressure. There's nothing that you can do, and send her back. So we prevented her from being admitted to the hospital. She stayed twice in an observation stay, less than 24 hours, and we got her back home. So normally, if we didn't have those tools in the home, we would get a routine situation of, the home health aide finds her, she's unresponsive, call the EMS, they'll transport her to the hospital. She gets multiple visits and checks, and then she's sent back home, or they're going to try and place her. What we've done is we followed what her plan of care is and what she wants. And we have collaborated with the doctor to prevent this from happening over and over again. So what used to be an ED visit is now a call to the doctor, guidance from the doctor, and then he addresses what we need to do.
I was going on the premise of the inability to hire in-home people. So I guess it would be somebody that was home alone, home by themselves, being monitored. And how would you prevent at that point in time?
Okay, well, what we have is we get an alert on our phone, the case manager, and what we will do is call that person immediately. And if we feel that we need to call UCM, United Concierge, to go and assess the situation, we'll do that. Again, we contact the family. Usually they might not be in town, but they might be out of town. But we'll address that issue as it comes because we get alerted. In the past, if you don't have that, then, that person is on their own.
And Nora, you probably want to address the alarm.com, where the camera in the home for someone that is home alone or have no caregiver. That's the piece. You want to address the alarm.com features?
Thank you.
Yeah.
I'm okay. I've got that now. I saw that, Lou. Thank you.
Yeah, and
Okay.
the sensors, there's a sensor in her bed. If she
Okay.
hasn't gotten out of bed by 9 o'clock, which she's out of bed by 9 o'clock every day,
All right.
we get an alarm.
Okay.
If she falls, there are motion sensors in the home, we get an alarm.
Okay. All right. That's what I needed to see. Thank you.
Her garage door went up at 5 o'clock in the morning. We got an alarm, and then we were able to literally trace her steps from the bedroom to the garage. And she opened the garage door herself. We could all tell that just by watching from the technology. And if I want to talk to her right now, I just push a button and we have a two-way communication. We have a two-way conversation.
Thank you, Lou. Thank you.
So you pay for the cost of all these sensors going in the house? Is that part of this program?
Well, that depends upon the funding source. For people who are private pay, they would pay out of pocket. For people who are not private pay, we're looking to get subsidies based upon existing technology subsidies. Medicaid has a technology subsidy. We're working with the Office for Aging, hoping we can find some way there to subsidize those installations. The technology, the only one that has a real installation cost is alarm.com. The others are all just monthly charges.
So that the senior, the person has to pay a monthly fee, right?
If they're private pay, they're on their own, and yes,
Yeah.
they're going to pay a monthly fee. But we've actually seen families where there are 3 and 4 children. They all want to be involved in mom's care. The 3 or 4 children pay, $50 or $75 a month, and they get the technology for their parent. So that happens quite frequently as well.
Linda,
But
you
again, you can compare it to the cost of a nursing home, which right now is $15,000 to $16,000 per month. This is a very minor expense to keep somebody independent and at home.
Supervisor Mustin?
So, what's the county's role in this? That's one question.
What do you want it to be?
And who's liable when things don't go right?
So that each company has their own insurance, and we have errors and omissions insurance. So if it's alarm.com technology that falters, there's a signed agreement with them, and they're responsible for their own technology. eCaring is the same. United Concierge Medicine, they're the telemedicine provider for most of the major health plans in the Capital District. So everybody is providing these services now independently. We'll have our own for the app and the care management services. But the question of the county's role, we are certainly looking to work with Kevin's group at the Office for Aging, and they've been very cooperative, and we've had some very good meetings where we exchanged ideas, exchanged information, and the commissioner, Greg Olson, is doing a few of these pilots in different ways across the state. This is one that he thinks has a lot of promise. So the state is very much looking to get this type of service available to people through all of the different payment modalities. Long-term care insurances, we didn't mention that, but we do have a number of clients that have long-term care insurance, which does pay for these services.
Lou, if I can just jump in there for a minute?
Sure.
And again, we've had a number of conversations, and obviously, one of our main concerns was, our staff is already, especially with COVID, has been pushed to the hilt. Okay, and we were, made assured that it's not going to cause any more work for us. Okay, and if it does a little bit, if it's going to be benefit our clients, great. And that's a standpoint that we've taken is, like I said, our role, I think, and Lou, correct me if I'm wrong, is to work with our state counterpart, this Mr. Olson, and be able to provide this group a number of names and addresses of people that were that are linked into us for services. And I guess they'll be sending letters out to them, seeking their consent and whether or not they would like to participate. And I think that's all our role is, at least at this point anyway. And like I said, I'm looking at this as, if this comes to pass, is that this will be of service to us, more of service to us, rather than more of us having to work more, or expand our caseloads. This is going to help enhance our caseloads rather than expand them. So, and Lou, if I'm speaking out of tune, just let me know.
You're right on point. And in terms of the staffing and the enrollment, we've budgeted a 6-month rollout, as Nora said when she went over the timeline, and that's rolling out 400 assessments over that 6-month time period, doing the installations, the implementations. Once all of that's done, the beauty of this is the app is active with artificial intelligence, collecting all of the data, processing it, and channeling it through to the appropriate parties. And this is all done with HIPAA compliance and with waivers from the family. But the primary care physician gets data, the hospital, if they need it, gets data, United Concierge Medicine, and the care manager, the person like Nora who's going to be overseeing the care, is linked with the family. And that's how they work now, collaboratively. This app is going to be the difference maker because they'll be on the same platform. And when you have the same information, the same data, communication becomes so much easier because everybody's working off the same platform.
Kevin, I think we've run an hour, so I think what we should do is, if there's a necessity, obviously, to have future meetings, that would be fine. We can set them up and have future conversations on this. If there's more questions from the group, we can forward them to Kevin, and then Kevin can get them to Lou and their group. But I think we should think about a wrap up here. It's been about an hour, so.
Well, I want to thank you all for your time, and you gave us a lot more time than you budgeted for, so we do appreciate that. And we wish us luck next week with the HFA board. We're hopeful that they come through and are willing to participate with us to get this launched.
And we thank you very much, all of you, for coming in and presenting to us. I think it's very interesting for all of us. So thank you very much.
Our pleasure.
Thank you.
Thank you.
All right. Bye.
Take care. Have a good one, Lou.
Kevin, is there anything else?
Nope.
Anything else from the group? Entertain a motion to adjourn. We have nothing else, right, Kelly?
Nope, that's it.
I'll make that motion.
And I'll second it.
All in favor?
Dinner
Aye.
time.
Thank you, everybody. Appreciate it.
Bye-bye now. There's all my buddies.
Okay, I don't want to get in front of the camera in case my underwear on. I jump out of my shorts.